Hello students, today we'll cover one more important topic, that is the anatomy of the uterine tubes, or also called as the fallopian tubes. This is Dr. Yusuf signing from Al University. This is the only specific objective which we'll be covering, that is the describe the anatomy of the fallopian tube. So it includes everything about the fallopian tube or uterine tube. So uterine tube is part of the female reproductive system. As you know, the reproductive system includes all the organs which are part of the female reproductive system, which are helpful in the reproduction in case of the female. So it includes the main primary organs, that is a pair of ovaries. So here you can see the ovaries, those are the main primary organs. Along with that, the other organs are the accessory organs, like a pair of uterine tubes or the fallopian tubes. Then we have the uterus, single vagina, as well as this is a part of the lower part of the uterus, which is called as the cervix. So all these are the accessory organs. The main primary organ is the ovary. Then the accessory organs are a pair of uterine tubes, the uterus, cervix, as well as the vagina. Today we will be discussing about the uterine tubes. These are the uterine tubes or the fallopian tubes. So these are the uterine tubes are a very important as well as tortuous ducts which will be conducting the sperm and the ovary towards a part of the fallopian tube called as the ampulla, the most important part of the uterine tube ampulla, where the fertilization will be taking place. So the fertilization will be of the sperm and the ovary will be taking place in the ampullary part, and these are the ducts which will be conducting the ovary from ova from the ovary, and the sperm from the testis, which is coming from the male. So there will be the duct which will be helping in conducting these two important the sperm and the ovary towards the ampullary part. Okay, so these are very important tubes which help in the mean fertilization of the sperm and the ova. It should be better to be said the fertilization of the ova by the sperm. Coming to the situation, these are present in the broad ligament. Broad ligament is nothing but a fold of peritoneum which is lying over the fallopian tubes. So it is a fold of peritoneum lying on the fallopian tubes, and this will be at the free margin of the broad ligament of the uterus. Coming to the parts, the uterine tubes are divided into four parts. The infundibulum, where there will be it is also called as the fimbriated end because of these finger-like projection. These are called as fimbria. So finger-like projection, these are called as fimbriae, and this end is called as the fimbriated end, or it is also called as the infundibulum because it looks like a funnel, reverse funnel. Okay, that's why it is called an infundibulum. The second part, which is the most important part, is the dilated part, which is called as the ampulla, where the fertilization will be taking place. Then the third part is a narrow part, as the name indicates, isthmus. So it means narrow. So this is called as the isthmus. Then the fourth part is within the wall of the uterus. Before this isthmus open into the uterine cavity, it has to pass through this wall, thick wall of the uterus. So that is called as the intramural part, or it is also called as the interstitial part. Okay, so this is the intramural part or the interstitial part, or it is also called as the uterine part because it is within the wall of the uterus. Coming to the communication, so it will be, this tube will be helping in communication from medially from the uterine cavity to the laterally it will be opening into the peritoneal cavity. We should remember that the peritoneal cavity is a closed cavity in case of male, but it is open in case of the female, and the only intraperitoneal organ will be the true intraperitoneal organ will be the ovaries. And because the ovaries will be releasing the ovum, so the fallopian tubes, a part of the fallopian tube even, that will be in the within the cavity. So the transfer of the oocyte from the ovary into the fallopian tube is within the peritoneal cavity. So laterally it will be opening into the peritoneal cavity, and medially it will be communicating with the uterine cavity. So this is also clinically important because if there is any kind of infection from the vagina, it might be transferred into the uterus, and from there into the fallopian tubes and into the peritoneal cavity. So even though it is rare, but still, because the peritoneal cavity is an open cavity, so easily in case of female, so easily the infection from outside can be transferred into the peritoneal cavity itself. So this is a tube, this is the fallopian tube. Laterally it opens into the peritoneal cavity, and medially it is communicating with the uterine cavity. So it is connecting the two. Coming to the dimensions, so the length of this fallopian tube is almost 4 inches in length. Total length is almost 4 inches or 10 centimeters in total length. The diameter differs at different sides. So even though the length is almost 4 inches, the diameter at different points will be different. So at different parts of the fallopian tube it is different. In the near the abdominal ostium, near the opening near the infundibulum or the fimbriated end, it is almost 3 millimeters in diameter. The ampulla, the most dilated part of the fallopian tube, where the fertilization will be taking place, that will be almost 4 millimeters. Then the narrow part, which is called the isthmus, will be almost 2 millimeters. Then the intramural part will be which is within the wall of the uterus, that will be almost 1 millimeter. Even though the isthmus is here, isthmus should be the narrow, but here, even though it is called as isthmus, it is not as narrow as the intramural part, which is almost 1 millimeter. So it will be passing through the wall. So because the wall is very thick in case of the uterus, so it will be the narrowest part, almost 1 millimeter in thickness, that is the intramural part. And the isthmus will be 2 millimeters, the ampulla part will be 4 millimeters, and the infundibular part will be 3 millimeters. So these are the different diameters of the fallopian tube at different parts of the fallopian tube. Coming to the arterial supply, it is mainly supplied by the uterine artery, which supplies almost 2/3 of the fallopian tube, and 1/3 will be supplied by the ovarian artery. So these two arteries, the uterine artery and the ovarian artery, will be anastomosing with each other below the fallopian tube, and they will both will be together, will be supplying the whole of the uterine tubes or the fallopian tubes. Coming to the venous drainage, the veins will be run parallel with the arteries, so that will be the mainly forming a plexus around these fallopian tube. Those are called the pampaniform plexus, and the pampaniform plexus in turn will be draining into the uterine vein as well as the ovarian vein. Coming to the lymphatic drainage, the lymphatic drainage of these uterine tubes will be into the lateral aortic as well as the pre-aortic group of lymph nodes, just like that of the ovary. These are also draining into lateral aortic as well as the pre-aortic. And the isthmus part will be draining into the superficial inguinal lymph nodes. So most of the part will be draining into the lateral aortic and pre-aortic. The most medial part will be draining into the superficial inguinal group of lymph nodes. Nerve supply is by both the components. Coming to the nerve supply. Nerve supply is by both the parts of the autonomic nervous system, that is the sympathetic as well as the parasympathetic. The sympathetic is from the hypogastric plexus. Both the afferent and efferent parts of components will be from the hypogastric plexus, and this is from the T10 to L2 level. And the parasympathetic is by two components. The vagus will be supplying on the lateral side of the tube, and the medial part will be supplied by the pelvic splanchnic nerve coming from S2, S3 and S4. So this is about the nerve supply. Coming to the histology part, we'll just briefly define the three parts of this. It has three parts. The outermost will be covered by a thin fold of the peritoneum, that will be called as the serous fold or the serous cord. Then the middle part will be highly muscular, and the innermost will be star shaped, very tortuous part of the star shaped structure, that will be the inner mucous membrane. So these are the three parts. For the more details, we will be discussing when we will discuss the histology of the uterine tubes in a separate chapter. Coming to the last component, that is the applied anatomy or the clinical anatomy. The first and foremost is the infection of the fallopian tubes or the uterine tubes, which is called as the salpingitis. Salpingitis is the itis, as the name indicates. Itis means inflammation and salpingo means the fallopian tubes. So salpingitis is very common in case of the female whenever there are infections of the any infections in the vagina and the uterus, it will be easily transferred into the fallopian tubes. This salpingitis, if it is prolonged, then it might lead to a condition called as sterility, where the female will not be able to give rise to any children. And this might be because of the inflammation itself, or it might be because of the inflammation which leads to the constriction as well as obstruction of the fallopian tubes itself. That might be also, or sometimes even the impatent developmental abnormality of the fallopian tubes. And sometimes even because of the salpingitis, there might be a condition called as tubal pregnancy. So usually the pregnancies, the fertilized oocyte or the zygote, fertilized zygote, will be developing. Usually the normal site will be, it will be in the posterior wall of the uterus, but it might sometimes it can follow an abnormal path, and it might be stuck within the fallopian tube itself, and then it is called as the tubal pregnancy. So if there is tubal pregnancy, it will be very dangerous, because after certain stage, when the fetus starts developing to a larger size, then the tubes doesn't have the capacity to expand just like that of the uterus, so they rupture and there might be severe bleeding. And if it is not identified in early stage, then it might lead to even death of the female. So tubal pregnancies are dangerous. Okay, so the other sites where there might be pregnancy, abnormal sites of pregnancy, might be within the abdomen. Okay, so after the fertilization, the zygote might come into the pelvic cavity or into the abdominal cavity, and then it might start developing. Sometimes it might be within the wall of the uterus, sometimes in the cervix. So all these are the abnormal sites, and the most dangerous will be in the fallopian tubes when it starts developing, and that might lead to rupture of the fallopian tubes, severe bleeding, and death. And the normal sterilization of the female after a certain number of pregnancies, the people might go for the sterilization, okay, where they don't want excess number of children. So at that time they go for permanent sterility, that is called as the tubectomy, where they will be passing probes and they try to identify the fallopian tubes, and they put a ring around these tubes, and then they even cut the fallopian tubes. Okay, so that is called as tubectomy, where they cut the fallopian tubes on both the sides. Okay, the part of the fallopian tube is cut and both the ends will be tied up separately. So that is called as tubectomy, and this is a female sterilization procedure. And in case of sterility, to identify whether the tubes are not blocked, whether the tubes are patent or not, so at that time they might do some tests, especially in case of if there is sterility in case of females, and they want to identify the definitive cause, and one of the cause might be the impatent fallopian tube. So to identify the patency of the test, they will be doing some patency test like insufflation test, or it is also called as the Rubin's test, where they will be passing the carbon dioxide gas through the fallopian tubes, and then this carbon dioxide will be released into, because it will be opening this ends, the fimbriated end will be opening into the abdomen, so this carbon dioxide will be released into the abdomen, and that leads to pain in the shoulder. So that is the sign. Or they can take an X-ray and they can see the gas within the abdomen. And they also measure the pressure by which they will identify whether there is any constriction of the fallopian tubes or total blockage is there. If there is blockage, the gas will not enter at all. So they will try to identify whether, if the gas has already entered, so by the pressure they will try to identify whether there is any structures. So that is called as the Rubin's test. Then they also do something called as the hysterosalpingography, where they pass a dye through the vagina. They pass a probe, and from there they pass the dye into the uterine cavity, and from there into the uterine tubes. Okay, so here you can see, here this is the X-ray taken after passing the dye. So the dye has been passed, and you can see the patent uterine cavity, and these are the fallopian tubes where the dye has passed on either side. And if the dye is passing, then they see for the spillage. So if there is a free spill into the uterine cavity, into the abdominal cavity, then it means that the tubes are patent on either side. Okay, so this is how it looks like if there is free spillage. So free spill of the contrast from the patent tube. Okay, so this is how you can identify the patency of the fallopian tubes. By one is the Rubin's test, and the second is the hysterosalpingography, where you pass a dye and then take an X-ray to find out if there is any blockage. Okay, so these are some of the applied aspects related to the fallopian tube. One is the inflammation, that is the salpingitis, then the sterility, tubal pregnancy, female sterilization, which is called as tubectomy. And to test the patency of the tubes, then it is called by two tests. One is called as the Rubin's test, or it is also called as the insufflation test, and the second one is called as the hysterosalpingography. So this is all about the fallopian tubes or the uterine tubes. If you have any questions, you can definitely write to me, and I will try to answer. So these are my references. If you have any doubts, you can definitely ask. Thank you very much. If you like this video, please press the like button, and if you want to see more of my videos as well as get regular updates, then you can subscribe to my channel, and you will be getting regular updates regarding the my lectures. Thank you very much.